I've been really looking forward to this episode because heart health is something that is just something that I feel like I'm just trying to consume as much information as possible. This is the Man Up Podcast, a doctor's guide to men's health.
If you've been enjoying listening to our podcast, please hit the subscribe button on YouTube, Spotify, and Apple Podcasts.
My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. This week's episode is titled Heart to Heart Conversation about Cardiovascular Health. In this week's episode, we're going to be joined by Dr. Dapo, a preventive cardiologist at the Miami Cardiac and Vascular Institute. And, Justin, I've been really looking forward to this episode because maybe my age range, I'm right there, but like heart health is something that is just something that I feel like I'm just trying to consume as much information as possible.
Yeah, it's one of these things that is all over the internet, obviously, and we talk about heart health with relation to erections. We're going to kind of take a little step back from that because we've kind of pounded that into the ground at this point. We're going to actually talk about a lot of things regarding heart health, things that you should be doing. Dr. Dapo, actually, we know each other from Miami. He's at Baptist, but we also lived in the same building back in the day. Residence, Millicento. So good. Welcome to the show. Thanks for coming on.
Thank you, guys. It's great to be here and looking forward to it.
Awesome. So let's get right into it. Heart disease, we talk a lot about testosterone, we talk about erections, we talk about cancer, but believe it or not, heart disease is still the number one killer of men. Why aren't people as afraid of heart disease as they are of other things like cancer? Is it still in the back burner here when it comes to men's health?
Yeah, it's a great question. I think about this often, and because year in, year out, we publish data and it shows that heart disease is the number one killer of men and women in the United States and globally. Yet it doesn't really ignite that sense of urgency in people. And I think it's maybe because it's so familiar. People have heard about it time and time again. You hear a lot of people have it. There's really no face of heart disease. It's largely a silent process until it's not. And I think people think it's just an unavoidable part of getting older. It happens to everyone. And the truth is really that it begins, the process of plaque and a lot of our heart diseases begin earlier in life. So as early as in your 20s or 30s, we already start to see plaque develop or fatty streaks in the arteries. And despite all of the advances in medicine, today, the most common way that someone will find out that they have heart disease is when they're having a heart attack or they're having a stroke or they're having a sudden cardiac death, unfortunate event. So, I like to tell people, yes, it is a part of aging, but because we're not doing a good enough job at prevention. And so for people who know that they have risk factors, and I think many people, and we'll talk about this later, but many people just have no clue what their risk factors are. But for people who have risk factors, I think we often normalize them. Oh, my pressure is a little high. Yeah, everyone in my family has high cholesterol, or, I'll deal with it later when I'm older. Whereas cancer, on the other hand, is a visceral and terrifying thing. Cancer has a face, if you will. Heart disease really doesn't. Even the cancer treatments are very visible, chemo, radiation, hair loss, weight loss. Whereas when we're treating risk factors for heart disease, people feel nothing. Even people who have known heart disease and we're treating, they feel nothing. And preventing an event doesn't feel or look like anything. So it's I think all of these contribute to why people aren't as afraid of heart disease as they are. Eventually that fear comes, but it's often too late. We see folks who, you see a dude come in and he's super fit, he's 45 or he's 50, he doesn't have a doctor, doesn't think he needs one, and he's being wheeled in with a heart attack into the ER. We're rushing him up to the cath lab. And that person will never forget that day. And the fear that you see in their eyes is something that you don't want to see again. And is why I go to work every day to to try to educate and raise awareness and prevent that first event in our men and our women.
Wow. So, I mean, you made a lot of great points there. I do completely agree with you. And and it's good that now we live in a time where there's much more media exposure or, social media that can bring more exposure about things that we can do. But I agree with you. There's a sense of like, well, I think heart disease is going to come at some point. But you know what? I still got many years ahead of me. Like, I'll worry about it when that time comes. But yeah, I don't want to find out by having a
It's
heart
a
attack.
crazy fucking idea, dude. That's like, it's giving me anxiety. It's like, yeah, you're just you'll get a heart disease at some point. It happens. Like,
yeah, no, this is, even amongst physicians, a lot of times, we're taking care of other physicians in the cardiology clinic. And, it's just something that we've been kind of just, it's been such a big issue for so long that we're kind of immune to it or just kind of, it's just a part of life. And I think now is the worst time to have that mentality because we have so many tools, so many treatments, so many preventive strategies that we can really do something. Whereas back in the day, I mean, if you found out 30 or 40 years ago that you were having a heart attack, you would lay in the hospital, get aspirin and morphine and just wait it out.
Jesus.
So we've come a long way in just 40 years. And I think the next 40 years is going to be even more incredible.
Amazing.
So,
Daph, I want to ask you something because you kind of mentioned it along the way here. And it affects me personally just because, you talk about how like someone can look fit and can look like, look great. You look at Justin, you're like, yeah, high risk, for heart disease. I'm just kidding. I'm kidding. But, I've actually had, people I know who just look completely fine, go to the gym, everything fine, and then, have a cardiovascular event. So I want to ask you, like, I mean, evidence shows it, but can someone look fit and still be at high risk for a heart attack?
yeah, absolutely. And I had a good friend from high school who now I think like 10 years ago, and we're the same age. So, yeah, he was around late 20s, early 30s, had a bypass surgery after chest pain. This dude is smaller than me, runs, is super fit. And so what I'll say is this actually happens quite a bit. I have a number of 30 something year olds in my clinic. And yes, some of them are people who have risk factors, but a lot of times they don't have any modifiable risk factors. And so to answer the question, I would say absolutely someone can be high risk despite looking fit. We know about this skinny fat, or we call it TOFI, thin on the outside, fat on the inside.
That's a real name for it? That's the real name?
The TOFI.
Yeah.
I mean, these are things that nerds in preventive cardiology have come up with over time.
That's so cool. Skinny fat has a medical definition.
Yeah, I don't think you'll find that in Bates or Braunwald, but definitely it's used, so thin outside, fat inside. And this really refers to people who carry, quite a bit of visceral fat. So this is the fat around your organs and not the fat that you can see from the outside. And when you have all this fat on your organs, it triggers metabolic dysfunction. And that ultimately leads to a number of issues, heart included, but can cause issues with the liver, issues with the kidney, with the pancreas, et cetera. The most important thing I would say when it comes to fitness, someone looking fit and still being at risk for a heart attack is that genetics plays an incredible role in terms of your cardiovascular risk. And so knowing your family history is super important. Knowing your numbers. So you can be fit and have high blood pressure. You can be fit and have high cholesterol. You can be fit and have diabetes. I did residency with someone who had a genetic predisposition for diabetes. And she's a marathon runner and had prediabetes at the age of 21, 22.
Crazy.
And so someone someone can look fit and still have those risk factors. And when we talk about developing heart disease, it's especially in the genetic predisposed population, they've had high cholesterol since they were, 3 years old. So you're talking about by the time they check their cholesterol for men, usually we don't check until we're 50 or so it's been almost 50 years of your vessels marinating in very high cholesterol or high blood pressure, which a lot of people don't feel, or diabetes, which people don't feel until they have an event or something bad happens and they end up in the ER and end up with those diagnoses. So I think that the key is no matter how fit you are, a six pack looks great, but unfortunately it doesn't tell me what's happening inside the coronary arteries.
I also would just add to that, from a men's health, like urology standpoint, we know that guys are blasted off of anabolics. They're blasted off on like super therapeutic levels of TRT, which we know can, at those high levels, put you at significant cardiovascular disease risk. So, when you're talking about super therapeutic, those guys are fit, but there's a reason why all wrestlers are dead of heart attacks by the age of 55, right? There's a reason for these things, and they're all having heart attacks. It's because of what they were doing to their bodies. Although they were these specimens, that's what they were doing to their bodies back then. So
Absolutely.
I wanted to add that. Now we've kind of mentioned cardiovascular disease risk. Can you give us some major risk factors for cardiovascular disease, and kind of, if it's possible, give us a breakdown of how much of that, if we have an understanding, is truly genetic versus lifestyle in putting you at future risk for cardiovascular disease?
Yeah, so I would say in terms of risk factors for heart disease, the most common is going to be high blood pressure. The most studied is going to be high cholesterol, high LDL cholesterol to be specific, or ApoB cholesterol, smoking, sedentary lifestyle, poor sleep hygiene, diabetes or high blood sugar, and then psychosocial stress. So high stress levels, all of these contribute to overall cardiovascular risk. And then we have our risk enhancers. I won't go into that. It's a long list, but they're risk enhancers. But those are our big risk factors. In terms of kind of what proportion of risk is due to genetics, I don't think we can put a number or a percentage on it. I like to say that genetics, loads the gun, and lifestyle and diet pull the trigger.
I like that.
So you know, although there's no single percentage, we know that there are some inherited conditions that are quite prevalent in our population. So elevated lipoprotein A is about 1 in 5 people globally. So we're talking about, 1.4, 1.5 billion people. Familial hypercholesterolemia, so this is super high LDL cholesterol levels, is 1 in 250 people. There are certain kind of heart muscle conditions or cardiomyopathies like hypertrophic cardiomyopathy, which, we see oftentimes those cases where there's a basketball player or a soccer player who, drops on a field suddenly at 16 years old. A lot of those cases are due to hypertrophic cardiomyopathy, which then triggers an arrhythmia. And that's a condition that's 1 in every 4 to 500 people. And the more we do diagnostic testing, the more we find. So there are numbers saying that it's even as low as 1 in every 300 people. So these are quite common, but they're not, they're not verdicts. They're more like early warning signs. So it's important for you to know what your risk is, if there's a genetic risk, and then do everything possible to control what you can control. And at the end of the day, what we try to do is, we can't change your genetics. We can't change who your parents are, but we can control the modifiable risk factors. So we can control cholesterol, blood pressure, smoking, physical activity, diet, etc. So we try to do those as well as we can.
Love that. Love that. So let's get into it. Let's talk about these modifiable risk factors, or, let's get to cholesterol. That's like the big one that is typically talked about. You've dropped now a couple of the cholesterol markers, like LDL, you mentioned ApoB. So why don't, as a primer for our listeners who are maybe you're listening for the first time, learning about this stuff, when should people be checking out their cholesterol levels, and what specifically, what markers should they be looking at?
Yeah, so we currently recommend, and this may surprise some people, but we recommend getting your first cholesterol level checked between the ages of 9 and 11.
Wow.
Years old?
Yeah. Yes.
Yo, your kids, Kevin, got to get close.
My kids are 9.
So
Who does that though? Do people actually, are
yeah,
people
I
doing
mean,
this?
we rely on pediatricians obviously to do that. And it's really more about awareness and educating providers. No one really wants to do blood work on a 9-year-old,
Yeah.
Yeah.
but what we know is that when you have, I said it's one in every 250 people, or those 9-year-olds, one in every 250 will have severely elevated cholesterol. And you can detect that as early as 9, and you can treat it as early as 9. So that's where the 9 to 11 age range comes in. A lot of our therapies are approved starting in that age group. So we recommend 9 to 11 to do a screening cholesterol panel. And then again, somewhere in your 17 to 21 age range, so college age.
So most guys are late.
I would say most
guys
people
are later.
don't do either.
Yeah.
Most people have no clue at 21 even what their cholesterol level is.
Yeah, I would say that's fair. I don't think I think even 35-year-old men don't know what their cholesterol is. Let's be honest.
Absolutely. I think your average 35 or 40-year-old guy has no clue what his blood pressure is or what his cholesterol is. And so that's kind of where, we need to do a better job of getting the word out, not making it a scary thing. It's not always a reflection of something you're doing. So we mention genetics a lot here, and cholesterol. A lot of times there's a genetic component, whether it's a clearly identified or described genetic condition, or it's something more polygenic, we would say, and that's something we're learning more and more every day. In terms of your cholesterol panel, so when you go get your blood work checked, you'll see lipid panel or cholesterol panel. It's going to give you usually at least 4 numbers, which is going to be your total cholesterol, your LDL cholesterol, your HDL cholesterol, and your triglycerides. Of those 4 numbers, the most important one, and the one I look at first, is going to be your LDL cholesterol. LDL cholesterol is not only associated with plaque, but is causal or is directly linked to plaque buildup in the arteries. So lower LDL cholesterol over one's lifetime, or what you call lower for longer, is a catchphrase that we use a lot now, equals lower risk. So LDL cholesterol I look at first. The next number I probably look at is either the HDL or triglycerides. I'll talk about HDL because a lot of people have heard about HDL. It's your quote unquote good cholesterol, whereas LDL is your bad cholesterol. And many times we'll get where people say, hey, my LDL is really high, but my good cholesterol is also really high. And those cancel out. This is kind of an old way of thinking. And what we know about HDL, and the way I use HDL, is really more of a reflection of your lifestyle, your diet, your overall health. But I also look at it because there are genetic conditions where people will have genetically lower HDL cholesterol and higher triglycerides. So we know in certain populations, like the South Asian population, so Indian, Pakistani, Bangladeshi, that's a population where that if you looked at the average weight or the diet in that part of the world, it's not necessarily one that you would think would predispose you to heart disease, but the heart disease rates in that part of the world are greater than a lot of other areas in the US. Yes. And so there's a lot of research into that right now because we've seen it. Cardiologists have been seeing this. When I was in residency, we would say, hey, if it's a 45 or a 50-year-old guy who's South Asian and he's coming in with symptoms, don't ignore it. Like, definitely look, because there's a high likelihood that he has disease, and not just mild disease, significant disease. And a lot of times in that population, you'll see that the HDL is low despite eating, all the right things, beside exercising, beside being a normal weight, not smoking, etc. So HDL can tell me a few things. One thing that's important about an HDL is that every time we've tried in research to raise HDL with a therapy, it's never correlated with a reduction in risk.
Mm.
So we've tried
Interesting.
a number of ways with niacin, with omega-3s, with a lot of different therapies, targeted therapies to raise HDL, and all of those trials have been negative, which is interesting. So it means, you really have to do it. It really is truly a reflection of the work that you put in for most people. And then the other interesting thing about HDL is that after a certain point, the HDL actually becomes a risk factor. So this is
You're just fucked.
so for men, that's usually somewhere in the I would say high, around 80 would be the number, 80 milligrams per deciliter, and for women
Check
it's
mine.
around 90, low 90s.
Okay.
And so what that is that after a while, you have so many. HDL is just another cholesterol particle. And when you see an HDL in the hundreds, 120, et cetera, a lot of those cholesterol particles are not functional. HDL is kind of like a cleaner, if you will, and helps with kind of cholesterol metabolism. After a while, you have enough HDL, and the rest of those are just floating around in the bloodstream and then can contribute to disease and et cetera. So it's this U curve of, increase HDL, lower risk, and then higher HDL, your risk goes up. Triglycerides, I'll quickly touch on. Triglycerides also important. We, in cardiology, we have not, over the past few decades, we've tried to correlate triglycerides with heart disease, and we just can't. No matter how you design the trial, et cetera, et cetera. There's only been one study that has been shown to actually reduce cardiovascular risk by lowering triglycerides. And that was a REDUCE-IT trial with a purified EPA-only fish oil in people with diabetes and high risk, or people with known disease. And so if you pick up a bottle of fish oil or on the over the counter, if you look at the back, you'll see EPA/DHA, or it'll have two lines, EPA this much, DHA that much. And every time you try the combination fish oil, there's no benefit. Yet
Ooh,
99% of the fish oil supplements on the market are going to be the combo. But they've gotten smart and have learned, they know that we prescribe EPA only fish oil. And so if you look on Amazon or whatever vendor, you'll see like EPA Max or EPA Turbo, EPA Plus, and it'll still be EPA and DHA if you look at the back. So mainly our goal for triglycerides is primarily preventing pancreatitis. So when the triglycerides get above 300 and more, so when they get above 500, there's an increased risk of spontaneous pancreatitis. So we lowered triglycerides for that reason. And we have new drugs that just got approved in the last year or two that do a phenomenal job at that. And their indication is lowering people with genetically high triglycerides. We're talking about thousands in terms of how high their triglyceride is, for the purposes of reducing acute pancreatitis episodes. So nothing to do with heart disease. Still studying, people are still looking at if we can find that relationship, but we still haven't.
So
I would say the most important thing is LDL.
LDL. I mean,
Short
this was really important for me. I didn't know shit about like that, honestly. Kevin, did you know a lot about this? I knew good and bad.
I've gone deep on it. And so I want to ask you, since we have you, you've given us great numbers here on HDL. You've talked a bit on triglycerides. Online, you're going to get, and next question, we're going to talk about statins and all around that. But from your perspective and from what you understand, should we be just trying to lower our LDL as much as possible? What number for you becomes worrisome? And then should we be getting these into you're seeing people out there saying I got to get my LDL down to 30 or something like that. So, is this factual, or is this true, or is this just all made up?
Yeah, I think you have different camps of people when it comes to LDL lowering. What I'll tell you is what my recommendation is for my patients, and this is based on our guidelines, which luckily we just got new guidelines in 2026, cholesterol guidelines. So this is kind of fresh, is that your LDL level should depend on your risk. So if you're a low risk person, an LDL level of less than 100 would be ideal.
For low
Previously,
risk.
for low risk.
Wow.
Yeah.
Okay.
As the risk goes up, and we calculate risk in a number of ways. It could be based on blood work, family history, genetics, calcium scores, which I think we'll talk about later, etc. As your risk increases, your target LDL or your goal LDL should go down. Because what we know is that as you go down on LDL, you're reducing risk. So if someone is already low risk, me lowering their LDL to 30 is taking them from 1% risk of heart attack to a 0.1% risk of having a heart attack. It's not as beneficial or necessary as a person who has a 30% risk of having a heart attack in the next 10 years. And we're lowering that to 5% or we're lowering that to 4% by dropping their LDL cholesterol. So the numbers that you'll hear used are going to be 100, 70 for most of our high risk patients, 55 for anyone who's had a heart attack or an event or a bypass or a stent, less than 55. And then in Europe, their very high risk population, their guidelines say to aim for an LDL less than 40. The folks who talk about really, really low LDLs, 20, 30, what their premise is that when you look at infants or you look at indigenous populations around the world, they have LDLs very, very low. And their risk of heart disease is very, very low. So the premise is our physiologic level of LDL is much, much lower than what we're comfortable with. So an LDL of 100 is not a physiologic level. You don't need an LDL of 100 for anything. An LDL of 100 certainly is worse than an LDL of 20. And so they would say, hey, why don't we get to physiologic levels? Let's try to match populations who are not exposed to all the things that we're exposed to, which raise our cholesterol. Abundance of food being amongst them.
Now, now I'm going to ask another question to follow up to that, because obviously this is something that you see online. You see a lot of people talk about. Is there an age, is it just risk factor, or is it based off, is there an age cutoff for that as well? Like, should the guy who's, we see guys, they're 40 years old, they're in great shape, they want their LDL to be 30, maybe they have no risk factors, or like a 25-year-old guy comes in and he's like, hey, I just want I want to get worked up. I want my LDL lower. Is it worth aggressively doing something to achieve that? Probably not, but you tell me.
Yeah, no, my answer would be no. It's really, you're looking at kind of risk benefit, cost to benefit ratios or equations whenever we do something in medicine. And for treating someone with a statin, honestly, it doesn't matter if they're 75 years old, if they're low risk, I'm not going to put them on a statin or any lipid lowering medication. Because if they've made it to 75 or 80 without disease or without an event, the likelihood that they're going to make it to 90 without an event is pretty good, especially if they don't have the risk factors for it. So I'm not helping them by putting them on a medication. I can make the numbers look very, very nice, but I'm not actually helping you. I'm not significantly reducing your risk of having an event.
I love that. I love that. The way you said that, right? Where it's like, I can get your numbers lower, but am I helping you? No, that's a fantastic way to put a lot of things in medicine, right?
I mean, especially testosterone, all these things, right? It's such a great way of saying it, right? Yeah. That's a really powerful way, because, this is what happens in the biohacking world. They get fixated on numbers, and people come in, they freak out about their T dropping 50 points to 100 points, but it's not going to help you. That was a really good way of putting it.
So go ahead.
Well, so let's, we've been circling around it. We keep using the word statin, and, you're blasted online by people who say like statins are like some sort of like, pharmaceutical, some insidious thing, and how they're terrible for you. While you have the other camp where they're like, yo, everyone should be on a statin, because again, they're trying to get their LDLs down to 20s, 30s. So why don't you tell our listeners what a statin is? When should they be taking it? You kind of already touched on like the low risk patients who are older shouldn't be. And then in general, are they safe?
Yeah, so I would say both of those camps of people that you mentioned are wrong. The people who think statins should be in the water are wrong, and the people who think statins are poison are also wrong. Statins are they're one of, if not the most rigorously studied medications that we have in all of medicine. I cannot name I forgot the number of studies that have been done on statins. They've also been out for over 30 years, proven to be safe, proven to be one of the most effective classes of drugs in medical history. Part of the reason why we've been able to reduce death from heart disease over the past 30 years is because statins were created and made it to the market. So what I'll say about them and first how they work. So they work in the liver, and what they do is they act on the cholesterol creation pathway, and they block one of the enzymes there. And so they reduce the amount of cholesterol that your liver makes. And so what your liver does when you stop it from making that cholesterol is that it pulls cholesterol out of your bloodstream and uses that. And so when you check your blood, you'll see lower cholesterol levels on a statin. So that's essentially how they work. And all of our cholesterol lowering medications work in this way, directly or indirectly. In terms of who should be on a statin, we talked about it earlier. I would say what's important is really to talk about those kind of clear and cut cases. So this would be people with known plaque-related disease. So that could be plaque in the heart, plaque in the neck, plaque in the legs. They've had an event or had a bypass or stent or some kind of procedure for a plaque-related disorder, plaque-related disease. They should be on a lipid-lowering therapy, and the first line is statin. Then people who have an LDL cholesterol of greater than 190. And that's because the likelihood of you having a genetic reason for that LDL being greater than 190 is pretty high at that threshold. There are caveats, and I have a number of anecdotes about very high LDLs that come down without medication. And then most adults, well, we recommend all adults who are age 40 to 75 who have diabetes should be on a statin. And that's because we know from a really large registry called MESA, multi-ethnic study of atherosclerosis, that even when you do a calcium score, and we haven't talked about that, but it looks for plaque, even if they have no plaque. If I check your coronary arteries today and you have no plaque, but you have diabetes, your risk of having a heart attack or stroke over the next 10 years is still about 9%. And our threshold for using a statin is, well, it used to be 7.5% with our old equation. Now it's 5%. So if you have greater than a 5% risk of having a heart attack over the next 10 years, then we should be using a statin. In terms of safety, I'll mention a couple of things, like kind of the big hot topics. One is muscle symptoms. Muscle symptoms are real, but they are rare. Depending on what study you look at, it could be 2% to 11%. A lot of these muscle symptoms, when you study them in randomized trials and you blind people to statins, to whether or not they're taking a statin, you find out that a lot of the muscle symptoms are from something called nocebo effect. So if I tell you that I'm giving you a statin, but I give you a sugar pill, you're more likely to have symptoms than if I tell you I'm giving you a sugar pill. So it's the fear of the side effect that kind of brings about the side effect that you're fearing.
So
But this
crazy.
happens a lot of times, I think, in other parts of medicine as well. So the muscle side effects, very rare. I don't dismiss or second guess someone if they tell me they're having side effects. Fine. We have a lot of options. There's also a small increase in diabetes. This is usually for people who are already at risk for prediabetes or diabetes. So they're on the border. We use something called a hemoglobin A1C to measure this diabetes or prediabetes, and it raises that number by 0.2%. And this risk increases as you go higher on the statin dosage. So that's something that I'll keep in mind. So if someone is, right on the border and they're, you know, right on the border of getting diabetes, and I don't want them to end up with that diagnosis, then I may be a little more gentle with the statin. But a lot of times for people that we're using statins on, the risk reduction from that medication actually cancels out that small increase in the blood sugar. And then lastly is dementia. So dementia, we've looked at dementia a ton. Most recently, there was a study called the Sprint Mind study. It was a sub-study of another trial, and they found that there was no cognitive impairment, no increased risk of dementia. In fact, what you found was that most types of dementia decreased in people who were on statins. The where people get this idea from is that the brain needs cholesterol to function. Statins do not lower the cholesterol that you need for your brain to function. Statins, for the most part, are lowering excess cholesterol. Your brain makes more than enough cholesterol intracellularly for it to function, and the statin is not going to affect that at all, even at very, very low levels. What else?
I mean, so you're telling me that Big Pharma is not putting something in my statins to control, keep me sick. Is that what you're saying?
Yes. And yes, Big Pharma is not trying. Big Pharma there is no Big Pharma when it comes to statins. So that's another thing.
Are you getting paid by Big Pharma to be on here?
Yeah. I mean, statins are basically free. I mean, it really, there's no one who's making money off of statins. No one at all. So that's another big fallacy that's out there.
No, and it's important to say that because people don't understand, it's a generic medication at this point.
Yeah.
Now, we mentioned a couple of other things. We're going to get to the coronary calcium score in a second, but a lot of this conversation I see online about ApoB, ApoA, these kinds of tests. Can you explain what these tests are, when we should be getting them, what they mean, and if they're helpful or not?
Yeah. So, in short, when we talk about ApoB, ApoB refers to the number of atherogenic cholesterol particles in the bloodstream. So all of our plaque-causing cholesterol particles have ApoB sitting on them or wrapped around them. So this includes LDL cholesterol, has an ApoB on it, VLDL, IDL, and then lipoprotein A also has an ApoB on it. So when we check the ApoB level, we get kind of a comprehensive number of all of the cholesterol particles that contribute to your risk. It's especially helpful in people who have metabolic syndrome, insulin resistance, diabetes, obesity, in that population, because you can have a discordance between the LDL and the ApoB. So if you're just looking at the cholesterol panel, you don't have an ApoB in someone with diabetes or obesity or metabolic syndrome, you may see an LDL that looks normal. Because the way I describe it to patients is, if you want to know whether you're going to have traffic on the road, I can tell you on average the number of people in each car on the road. So I tell you there are 3 people per car, or there are 5 people per car. And maybe that means there are a lot of cars, maybe it doesn't. Or I can tell you the number of cars on the road. And so what's likely to correlate with whether or not you're going to face traffic is the number of cars on the road. Doesn't matter if there's 1 person in each car or 10 people in each car. LDL that you get on your cholesterol panel is telling you the number of people per car, whereas ApoB is telling you the number of cars. So you can imagine a situation where there are a lot of cars on the road, but there's 1 person in each car. And if you're looking at the average number of people in the car, you're going to think that everything's okay, but there are actually a lot of cars. And this happens in insulin resistance, diabetes, metabolic syndrome. And so it's super important to check the ApoB, and our guidelines now recommend especially in that population, if not in everyone, that you should be checking an ApoB to confirm your findings on the cholesterol panel. Lipoprotein A, I mentioned it
Quick
earlier.
question. What age is that? Like, so should a 30-year-old man be getting the ApoB?
Yeah.
Like,
Yeah.
Oh,
I
really?
think as long as you're getting a cholesterol panel, you should get an ApoB.
So you should always ask, like, if you're going to a primary care, you say, hey, give me a lipid panel, get me an ApoB at the same time.
Yes.
That's a
Yes.
really important point because
Absolutely.
usually I'm just asking for a lipid panel. I think a lot of
Mhm.
people don't know. So you it's a different era now. It's not 30 years ago. Get the lipid panel, get the ApoB at the same time.
Get the ApoB. Absolutely. If you were to get one number, cholesterol wise, if you were to give me one number, it would be ApoB. And I just manage you based on your ApoB, and you'll do as good, if not better, than the person who we're managing using the cholesterol panel. What I'll say about lipoprotein A very quickly is, it's gotten a lot of attention lately because we have a number of drugs in trials that, we'll hear about the first ever drug that lowers lipoprotein A later this year. And what it is identical to your LDL cholesterol. Like if you look at them side by side, they're identical, both with an ApoB on them. The difference, the lipoprotein A has this ApoA strand on it. And this is genetically determined. So about 95% of lipoprotein A in your bloodstream is genetically determined. That ApoA prevents it from being cleared by the liver, prevents our medications from reducing the lipoprotein A. There's no diet or lifestyle or anything that you can do to lower your lipoprotein A. So it's like having a high level of your LDL cholesterol since the age of 3, which is where lipoprotein A kind of stabilizes for the rest of your life. So that confers an increased risk. And so the higher the lipoprotein A, the higher your risk of heart disease. We know that it's also quite prevalent. So it's 1 in every 5 people on Earth. So 20% of the global population, and only 1% of the people on Earth have even ever had it checked. So there's a big push, for the past year and a half, 2 years, at every major cardiology conference, they've offered free lipoprotein A testing to anyone in attendance.
Wow.
And you see
cool.
you see the line wrapped around the conference center for people getting their lipoprotein A checked. And I wish I could take a picture and show that to the primary care physician, or show it to, the 30-year-old kid who thinks everything's, great. That, hey, this is what a room full of cardiologists are lining up for. Why are you not checking this? Why do you not know your number? And it's as easy as, without a doctor, everyone listening to this podcast and everyone out there can literally go to Quest Diagnostics website or LabCorp and click order lipoprotein A, and then go to the center and get it checked. It's about $30 or $40.
And that's something that Kevin has actually been advocating for a while, right? Like, you don't need sometimes a doctor to just get a baseline of labs to bring to someone. If that's the thing you need, you're scared to see a doctor, get the numbers. That may motivate you to go to the doctor, right, Kev?
Yeah, I mean, for better or for worse, what it is, I think it's all
Right.
positives. But yeah, at this point, you don't need, we're educating you, tell you what you need to look for and stuff, but you don't need to wait for a doctor to kind of write that prescription or to put that order in. You can literally just hop online these days and order your own tests and find out within a couple days where your numbers are at. And on that note, we're going to kind of talk about this other thing that you can kind of just hop on and just go order yourself now. Getting a lot of discussions because I think a lot of people are, I think more skewing now younger, like, oh, I got to go get my coronary calcium score or coronary CT done. And, it's, you hear all the, all people talk and they're like, oh, you got to go get that checked because you don't want to, die of a heart attack next day. So, Dapo, why don't you tell us, is this some test that every person should be going getting? What is this test? And, what's when should you be really getting?
Yeah, so the coronary calcium score, or CT calcium score, is probably the best test that we have in prevention when used appropriately. What it is a non-contrast CT scan of the chest, looks at your heart directly, looks at the coronary arteries, and then gives you a number that correlates with the amount of plaque that we see in the arteries. So that number could be 0, it could be 4,000. We have kind of tiers in terms of calcium score. 0 means you have no calcified plaque. 100 is the next tier, 300, and then over 1,000 is our highest risk group. Doing the calcium score in the appropriate person is super important, because if you do it in someone who's young, I mentioned earlier that the disease starts to form in our 20s and 30s. When it starts to form, it starts off as soft plaque or non-calcified plaque. This you're not going to see on a CT calcium score. So if you do a calcium score on a 30-year-old, if you do it on a bunch of 30-year-olds, 1,000 30-year-olds, you may get 1 to 10 people with actually calcified plaque, but the majority of them are going to be a calcium score of 0. And you don't want that to blind you to the person's risk because they have a calcium score of 0.
Makes sense.
Because they may have non-calcified plaque. So it's really, if someone has risk and you happen to do a calcium score when they're young, a calcium score of 0 in someone who's young is not a clean sheet the way that it is for a 50 or 60-year-old person. So it really was developed as a tool to help us in deciding who should get medical therapy. So if we're on the border, so then this borderline risk population, where we're not sure if we should use a statin or not, then a calcium score can help you with that decision. I use it a lot, primarily in people over 40. If someone has a family history or really significant risk factors, I'll do it as early as 35. We're doing research now to see if there's a population that would benefit at the age of 30. But right now, I think 35 in men with risk factors or strong family history is the youngest I would go.
Is this something that you have to do every 5 years or something? Like, how often are you doing this?
Yes. So if you have a score of 0, then you should repeat it in 3 to 5 years. The reason being that your score of 0 may have been 0 for calcified plaque, but you may have soft plaque. In 3 to 5 years, that soft plaque would have become calcified, and you would see it on that subsequent test. So 3 to 5 years is the time frame for repeating. Then, Kevin, in LA, a lot of people in LA and San Fran, a lot of people have really gotten into coronary CTAs because of this soft plaque issue. So coronary CTA is a more advanced test with contrast. So there's risk there, which can actually visualize soft plaque. That is really currently not indicated for people who are not symptomatic. So for prevention purposes, there's no indication. So your insurance is not going to pay for it. They also don't pay for calcium scores, but a calcium score is $99, as cheap as $50 at a lot of places. Whereas a coronary CTA you're starting at 1,000. And if you start adding, what we have now with advanced plaque analysis, it can get up to 2,000, 2,500, et cetera, for one test. More radiation, there's contrast. That should really be in a select group of people where the cost benefit makes sense.
So do you think there's a place for that?
I think Kevin, I love that. That's exactly the question, Justin.
Is there going to be a
place for Let's say the cost is up.
Right, exactly. Is there a role of this? Or in the next 5-10 years, do you think that there's going to be literature supporting this kind of?
Yeah, I mean, there are ongoing studies looking at coronary CTAs. Actually, here at our institution, we have one of the largest coronary CTA studies, the Miami Heart Study, where all of those folks got coronary CTAs with plaque analysis. And so there are registries like that. We're learning more about it. Right now, what I do in my clinic is, and this may not be for everyone, but if I have a young person and they have more plaque than I would like to see for their age group. So let's say, a 35-year-old or 40-year-old guy with a calcium score of 100, 150 or more, definitely above 300 for sure. I want to make sure this is someone who is at extremely high risk of having a heart attack or a stroke at some point in their life. So I want to make sure that I have all the information about their plaque and that my intervention, so the medications that I'm using to stabilize that plaque are actually working. And so the coronary CTA can help with that. And so I will order it. And someone, let's say, I have this patient that I just described, we're treating, everything looks perfect. Inflammation markers are down, cholesterol is down, everything's where we want it to be. And they're comfortable with paying that amount and they want to be sure. Then I will order it in that case and say, okay, let's look and see what proportion of your plaque is calcified, how much is non-calcified, how much is high risk non-calcified plaque, so low density non-calcified plaque, all of that information we can get on the coronary CTA. And so if I did see that despite everything looking good on paper, they have, 70% of their plaque is soft plaque, then I may change the way that I treat them to use a more potent medication to try to stabilize that plaque or even cause regression of that soft plaque. So that's kind of the way I use it. And we'll find out if that's something that should be scaled and used, in the broader population. Right now, it's not. But I think eventually it may be. We run into the issue of, how much information, what's that threshold where it's too much information?
Yeah.
And, it's a tough.
It's a lot of information, man. And like just giving tests to give tests never seems like a satisfying thing, although people want more tests. Apparently you have those two areas. You have the people who want every test under the sun, and then you have people who don't even know what tests exist. So you're battling both of them every day. It's a very weird time, right? Now, going towards every test, is there any other marker or biomarker or screening tool that you recommend that our listeners be asking their providers, their cardiologists, their primary care to assess their cardiovascular health that we haven't discussed yet?
Yeah, I would say in addition to the normal labs that your primary care is going to check, I would say ask them for a lipoprotein A, ask them for an ApoB, ask them for an insulin resistance score, or a HOMA-IR, and insulin resistance score is good enough, or fasting insulin if they don't know how to order the insulin resistance score. That's important because when you eat something, your pancreas secretes insulin, pulls down the blood sugar, stores it in muscle, etc. We start to see fasting insulin. So fasting, you haven't eaten anything for 8 hours. Your insulin level should be normal. It should be low. When we start to see that rise, that occurs about 10 or 15 years before people develop diabetes. So your hemoglobin A1C, your blood sugar may be normal, but it's because your pancreas is in overdrive controlling, keeping it normal. And eventually it's going to get tired, your body's going to get resistant, and your sugar is going to rise. So with the insulin resistance score or fasting insulin, we can detect that.
That is awesome. There's a lot of things that I learned today. Obviously, we had so many more questions, but we want to be respectful of your time and our listeners. We always usually wrap it up around 1 hour, but we're going to have you come back on because this was so informative. And I think we really highlighted some of the important things that obviously I think I'm going to have a heart attack now thinking about all of the things that I haven't gotten tested. I got to get a lipo A, I got to get an ApoB, I got to get my lipid panel, I got to get my fasting insulin, I got to get all of these things, and maybe a calcium score. I'm 38. Kevin definitely, he's old as shit, so he needs one. So yeah, but thank you so much for coming on. Where can our listeners find you? And then we'll close out.
Yeah, I'm
awesome. So beautiful. All right, this was really great. Thanks for breaking down all these ideas and concepts and the data behind all of them. For all of our listeners, as always, download, subscribe, give us a review on all podcasting platforms at The Man Up Pod on all socials. Follow there, give us a comment. Thanks for Kevin and I and Dr. Dapo. Have a good one, guys.